Thank you for the kind invitation. It's my privilege and honor to be here. This is my academic affiliation. I'm a simple emergency physician. So at the end of my residency, and my government sent me to Royal Infirmary of Edinburgh, and we learned excellent clinical emergency medicine. And my supervisor, Corey Robertson, told me that to make a diagnosis, it's 80% good history and 10% physical examination, and the rest will add on to another 5 or 10%. And 3 years later, for my advanced training, I was sent to University of Cincinnati, working with Dr. Brian Gibler. And at the time, CKMB was the gold standard for the diagnosis of MI. And he was doing a clinical trial with troponin T point of care, under Boehringer Mannheim before they were brought over by Roche. And in 1997, my lab chief sent me to this Bali meeting funded by Boehringer Mannheim, and Dr. Carter's, inventor of troponin T, and then Dr. Alan Wu and Elliot Edmund, and also the Reklik, I think from Sweden, and this Japanese cardiologist, I can't remember his name. And I was standing right behind, hiding right behind, and I was converted. So we got some money to do a randomized study, and Dr. Jacob is the late Dr. lab chief, and also we have this is my mentor Ananta, and then Terence Chua is the chief of nuclear cardiology, and we study patient present to ED with chest pain, suggestive angina, and non-diagnostic ECG, and also we exclude patient which is suggestive of typically, and that means they have a history of coronary artery disease, came back with the same presentation, and those definitely not cardiac chest pain. Again, is a clinical diagnosis and require admission for other concomitant medical problems. And so all the patients have 036 hours CKMB troponin, and then 2/3 will go to stress nuclear scan mandatory, and then 1/3 will go, the senior emergency physician will decide whether to admit or discharge. And for admission, we need to go through the cardiac fellow. And we follow up the patient for 30 days and 1 year. And this is an endpoint adjudicated myocardiac sort of adverse cardiac event, and also CAB, critical coronary artery disease. And this is the results of our biochemical biomarker, and you can see the ROC curve of troponin is quite impressive. However, the statistician give us the 95% confident ROC and all that. There's a lot of overlap between troponin T and CKMB. So we look at the result. We look at those with adverse cardiac events and the old sort of fourth generation troponin T, and 50% concordance and 30% both miss, right? And for those in between, troponin won most of the time, and so because of this, we swap overnight, all right, to troponin, and we never publish our result for various reasons, which long story we haven't mentioned. So this is the stress echo. The second row is stress image, and then the top row is the rest image. And you can the other way around. The stress image is the top, and then the lower row are the rest image, and you can see the sort of defect. This patient had a critical coronary artery disease, randomized to the stress nucleus. In fact, he was a garbage collector. Every time he pushed the truck, he got this neck pain and arm pain, and then we randomized normal troponin, conventional troponin. We randomized to this study, and however, it doesn't show any difference in outcome. All right, but it cut down admission rate, cut down the rate for coronary angiogram. And we are thinking of whether we should use clinical score to replace stress myocardial perfusion because it's quite expensive, and also limited sort of availability. And then for those who can't do there's about 20% of the patient which cannot do enough exercise stress, and these are the group of patients that will have a higher 30 days MACE, and so we don't think that exercise stress test, although it's cheaper, is a solution. And here comes the high sensitive troponin troponin. This is a landmark paper, and my chief of lab clinical chemistry summoned Terence and me to his office, and he said that we have to switch to high sensitive troponin because they are not going to produce conventional troponin anymore. So are we going to change the cutoff value, because the old value was 30, now we use 13. So we say no, because in 30 we already see some false positives, so we cut down to 13, it will be a crying wolf, So we say we kept to 30, but without knowing it, actually we already shifted our cutoff from 54 to 30, right? Because the two, that's how, the correlation between a fourth generation troponin and high sensitive troponin. So without knowing it, and this is a very important paper by Christian, one of my heroes. This is the first paper to show that we need two cutoff points, one for rule in and one for rule out. And so we no choice, we have to collect some data, and we finally published our data on patient, a same cohort of patient, and we found that it's almost a straight line. So when the level of high sensitive troponin go up, the PPV went up, go up. So actually, to define the cutoff point is quite difficult. The choice is I don't know, it's yours. And we also found that for the delta, it's +7, not for our population, it's +7. And you can see we choose 16 as our cutoff point because of a Y index. And even very low, 5, the negative predictive value is still quite not that high, it's 96%. And if we use so cutoff point of 30, it gives a PPV of around 50%, which is nice. And if we use 52, it's about 66.7 PPV. So this is we published, so this suggested, and the statisticians say maybe you should use 0 and 2 hours, 26, We give you a rule in about around 50%, 60% at that time. And if you use 0 and 2 hours, 16, it will, it is 97 negative predictive value. So how to cut down further? And then we thought about HUD score, and this is the HUD score, and I met Barbara Beckers 1 month ago in Amsterdam, so we took a picture. And according from our data, we found that, in fact, you want to have a MPV of 99.5, I think we should use cutoff 2 rather than 3. Okay, so we're comfortable with 2. And so we started our chest pain protocol. This is the exclusion-inclusion criteria. So all cases must be vetted by ED attending, and we excluded those with renal failure, as well as those have a raised baseline troponin. And you can see this is extremely complicated, So definitely we need some artificial intelligence. and this those with this. Yeah, so just to show, and also we say that patient who have persistent chest pain or dynamic ECG changes, we have to admit, okay? Yeah, so we need artificial intelligence. And then we went back to the previous study, the randomized study, because we collected very good history because we have a template, for collecting history, and it entered in our electromedical record, and the history are collected by the residents or medical officer equivalents. And we found that, and also every patient had a random LDL and HDL, and also sugar, all right? So this is our sort of coronary risk as well as the history, and it shows that, pain radiate to the jaw and neck, but not the arms, okay, associated with diaphoresis, aggravated exertion, relieved by GT, and these are our typical feature in our population. And then if the associated population is negative. And so we derive a score, and then we also found that, so please ignore on population, it shouldn't be there. About 13% of the patient with MACE has none of the typical symptoms. And about 73% of non-MACE has one of the typical symptoms. So this is live. So this history. And if you combine this score with troponin, we can sort of excluded about 20% of the patient, but those low risk group where you don't need any stress test, no need any further cardiac follow-up. And we can in fact, there's a very low risk group, about 63% if the score is less than 13, and this group don't even need to come to emergency department. So we also dissect of the previous data. These are the hard score, right? So the ECG score of them are 0. And we found that troponin, in fact, is the most important, highest positive predictive value. So if the troponin score is 1, this is conventional troponin, the PPV already 70.8%, so we don't have to talk about history or coronary risk factor. And there's one group of patients with very low risk, small group of patients. That means this group of patients don't have coronary risk. They have a normal LDL, normal HDL, as well as a normal random sugar. So it's almost 0. So again, they don't have to come to a hospital. Yes, and history is, the positive predictive value is not very high. It's about 10 to 20%. Right, so going forward, I think we need artificial intelligence, and Nick, as the anchor author of this paper, and this M13 show that if you put in the sex and the age plus the change in the troponin, you can get a better predictive value than the ERC guideline or the sex age specific cutoff. And of course, this is very, very Christian and Nick around the latest paper using the this dots, and it shows that there are multiple variable. In fact, you can even more accurately predict. Unfortunately, there's not many paper on this model on troponin T. So I think maybe it's time to explore that. So in conclusion, separate population-specific rule in and rule out cutoff values for high sensitive troponin are required. Like in the United States, Frank paper showed that it's 19. And then I also want to mention decrease in 2 hours high sensitive troponin to 16 does not predict MACE. So for us, if we see a decrease in 2 hours troponin T, it doesn't predict MACE, right? So it's different from other data, right? Different from the other the recommendation by AHA, ACC, ESC. And high troponin T have to be used in conjunction with age clinical presentation, coronary risk factor ECG diagnostic, so we may need an AI. And for heart score, we use rule out is 2 and rule in is 6. Okay, and beware, patient may have more than one pathology that can cause elevation of high sensitive level, and we have a patient present with urticaria and also have some chest pain. And then, in fact, he have urticaria with MI. So do beware. And a rule out MACE doesn't mean that the patient is okay. Aortic dissection and PE, very difficult to exclude. I think that's all. Thank you for your attention. And
Thank you for that lovely talk. I'm a student of the history of medicine, and it's wonderful going back to see the old Royal Infirmary. I remember Colin Robertson calling me down to that emergency department as a young SHO to come and see patients with abnormal CK and B results. And I was determined to prove that it was a false positive every time. And probably it was. But, it's interesting. And it's also good for the young trainees to see those pictures of the heart, the tiny hearts there. That's all we had back then, the tiny hearts. But we all have the same challenges, I guess, in how to incorporate symptoms, risk factors, and biomarkers into a pathway that works for our healthcare system. In Singapore, do you have a high prevalence of myocardial infarction? Do you think there are regional differences that mean that your pathway needs to differ from, say, a European pathway in Basel or a pathway in Scotland?
Yeah, I think this the cutoff point is based on the prevalence, and also how you define the 99th percentile of how stringent, you want to subject everybody to MRI, to stress echo, and the age as well. Usually in the 99% cohort, usually they choose younger patient, very few elderly, and that's why I think we need to have a different cutoff point. And again, it's a straight line, so you have to make a decision somewhere. And to find the most efficacious cutoff point.
I also liked your photograph of the troponin T expert consensus group in 1997, and I think it's fascinating that we're still debating how to use this test 25 years later. But thank you very much for that excellent talk.
Thank you.